All right, as chiropractors, we are often put into this box of just treating spinal cases, low back pain, neck pain, you name it, mostly just spine stuff. And it is true that when we are treating somebody, we're always looking at the spine first. But there are cases where it's just a shoulder and it's just a knee or an ankle. And we treat those a lot here. We treat a lot of athletes. But we also treat a lot of orthopedic pain that is just in the extremity. Today, I'm going to talk about a case of a mid-30s doctor that was an ex-athlete, had a lot of shoulder complaints, pitched, played football, played basketball, all those things, and may have had rotator cuff tears in the past. But never really wanted to have surgery or get this shoulder really looked at because it didn't cause him too much pain. But he's got kids now and he wants to be able to throw the ball around in the yard with the kids. And he doesn't think that with his current shoulder state, he's going to be able to do that. So he came in. We've been working on this shoulder just a little bit. And first thing is when he raises his arms, his right shoulder only gets just below 90 degrees of actual range of motion. So that's like an alarming thing. People and other doctors have told him that he has frozen shoulder syndrome. I would beg to differ that it's not frozen shoulder, but basically people don't know what it is, and so they throw out that terminology because it's not moving that full range of motion. So we did an exam. Basically, we test it. We're moving it. We passively move it, and then what ended up being a movement that actually helped him was going into flexion. And we did repeated motions into flexion that actually freed up his shoulder. In the first visit, like I said, his shoulder went maybe at about here. After doing, let's say, 20 reps of going in the flexion, I was moving his arm into a passive motion this way. We basically got his arm up to about here. Now, that was a really cool trick in our office, and it's a really good move that helped a little bit in here, but I never want to just say like, yep, that's exactly what we need to do. It worked, but we want to kick them out into the real world and see if that motion over time is going to still help that patient. Patient comes back in 2-3 days later, and he basically has full range. There's still some tightness in that shoulder. So we know this is what we would call a flexion shoulder derangement. Basically just means that the joint is not moving or is obstructed in some way, and we move it in a pattern or a movement that responds well for the brain, and the brain opens up that motion. Now, if you went to orthopedic or a PT, they would probably classically or medically diagnose this shoulder as a bicep tendonitis with a restricted joint. I mean, he still had some tenderness, like if we push here, it referred some pain, right? So medically, the diagnosis would be a bicep tendinopathy. But functionally in our clinic, we would call that a shoulder derangement, just meaning it's not moving. And the way that I like to explain this to patients is if you have a room in your house, everybody's got one that they just kind of store stuff away. It's kind of like their junk room. It could be a closet, things like that. If you've gone into it many times, you kind of have it mapped out how you could walk in and out, try to find things and stuff. And let's say it's an old school room and the light is in the middle of the room and it's one of those pull string lights. Let's say that light burns out. Now, the first day it burns out, you still might be able to navigate your way through that room in the darkness because you've been through it, you kind of have it realized. Now, after multiple weeks of not changing that light bulb, you're probably going to start running into things, bumping your toes, and be a little hesitant to walk into that room. It's kind of the same thing with our brain. We start losing a little bit of range of motion, or let's say we have a significant thing where we fall on that shoulder. the brain goes, "Ooh, I don't like that." It dampens down its receptors to it, or its sensory to motion in that arm. And then basically over time, we stop moving it in that direction, and the brain just keeps slowly dwindling down its range of motion and dampening its ability to effectively move in all ranges of motion through that shoulder. So all we are doing is basically reintroducing a movement that it didn't like. We don't really know the whole reason why, but we just know it worked, right? So we move in that range of motion, the brain is getting great feedback, and it's starting to open up. It's feeling comfortable again. So that's a really cool case. If you want to learn more about that, please reach out to us, and we can walk through, try to figure out somebody's shoulder pain and things like that. But that wasn't the end of treatment, right? So we got the shoulder moving again, but now we have to make sure that we rehab it in the correct way so that the shoulder can control and move and doesn't freeze back up. So one of the things that we do a lot with shoulders is work on shoulder stability. So we're going to do exercises and motions and things like that that are going to strengthen the ability of the shoulder blade to move as our arm moves. The shoulder blade is what stabilizes that shoulder, because the shoulder is like a golf ball sitting on a golf tee. It has a ton of range of motion. And so when you have a ton of range of motion, you also have a lack of stability. So that shoulder blade has to be really strong. And the shoulder blade is a unique joint because it's just hovering or floating over our ribs. And it has a bunch of muscles that control and navigate that shoulder blade so we can get that free range of motion. So we're doing the motion to try to relieve the pain and open up that shoulder joint. We're doing stability in that area. And then at the same time, we're also going to be doing some soft tissue, maybe to that bicep tendon that's getting beaten up because it's trying to control and tighten down, and it gets inflamed and things like that. So we're going to be doing dry needling, some ART, pin and stretch, and then actually just hands-on mobilization and adjusting. The other thing is we adjust the mid-back so that when you go to reach over your head, you still got to extend through your thoracic spine. So that's kind of a glance at what we would do for an extremity type case. And it shows a really good picture of what we do here. And it's not all about back pain and neck pain. So if you have a shoulder complaint, seriously, please reach out to us. I bet we can help you. If not, we're going to get you to the right people that can.